Okay, this is Chapter 8 of the ATI Maternal Newborn Infections. Maternal infections during pregnancy require prompt identification and treatment by a provider. During pregnancy, the client is at risk for developing infections that can cause complications during pregnancy that can affect the well-being of the fetus. It is important for all clients who are pregnant to get screened routinely during their first prenatal visit and during the third trimester for infections. A provider can perform testing during the client's pelvic exam or by obtaining blood, urine, or swab cultures. The initial antepartum screening tests include syphilis, hepatitis, HIV, gonorrhea, and chlamydia. It is recommended that the client have a current pap smear performed by a provider during pregnancy, which can detect dysplasia and HPV. During the third trimester, the client should receive testing for group B strep and retesting if indicated for gonorrhea, chlamydia, and HIV. Other infections that could affect pregnancy include COVID-19, torch infection, trichomoniasis, bacterial vaginosis, herpes simplex, and candidiasis. This chapter will focus on infections as related to clients during pregnancy. HIV and AIDS. HIV is a retrovirus that attacks the causes of destruction of T lymphocytes. It causes immunosuppression in a client. Clients who are severely immunosuppressed develop acquired immunodeficiency syndrome, which is AIDS. HIV can be transmitted by the birth parent during pregnancy to the fetus by the placenta and postnatally to the newborn infant through breast milk. The CDC recommends that all clients who are pregnant receive counseling and offered screening for HIV at their initial prenatal visit and in the third trimester prior to delivery. Laboratory diagnostic tests. Verify that informed maternal consent is obtained prior to testing. Clients who are pregnant should be informed that HIV testing will be performed as part of the routine prenatal panel. Obtain frequent viral load levels and CD4 cell counts throughout pregnancy. Nursing care, antepartum. Goal is to keep CD4 cell counts greater than 500 and prevent transmission to fetus. If the client is HIV positive and taking antiviral medications, they should be informed that they transmit the infection to the neonate. Refer the client if needed to a psychosocial support. Encourage the client to receive immunizations against hepatitis B, pneumococcal, hemophilus, influenza, and viral influenza. Vaginal birth can be an option for a client who has a viral load of less than 1,000. Avoid procedures such as amniocentesis due to risk of maternal blood exposure to fetus. Intrapartum. Plan to administer prescribed IV zidovudine. Administer 3 hours prior to scheduled cesarean birth and continue until after the cord is clamped. It is administered intrapartum for vaginal birth and given to infants for 6 weeks following birth. Procedures such as artificial rupture of membranes and episiotomy should be avoided due to the risk of maternal blood exposure. Wear gloves when caring for the newborn immediately following birth. According to WHO, for the client who has HIV and AIDS, exclusive breastfeeding may put an infant at risk for HIV. Postpartum, referral for specialists for birth parent and newborn management of HIV. Antiretrovirus therapy, or ART, is administered orally and continued throughout pregnancy. ART is a triple antiretroviral medication therapy that is administered by mouth, ritonavir or indanavir in conjunction with NRTI. All HIV-positive infected clients should be treated with a combination of ART during pregnancy regardless of other CD4 counts and prior to onset of labor or cesarean birth. ART can cause bone marrow suppression, monitor heme and platelet counts, and white blood cells during pregnancy. Highly active antiretroviral therapy. Intrapartum is IV zidovudine 3 hours prior to scheduled cesarean. Nursing actions is administered zidovudine to the newborn at delivery. Chlamydia is a bacterial infection caused by Chlamydia trachomatis and is the most commonly reported STI in American women. The infection can be difficult to diagnose because the client rarely has manifestations. The CDC recommends all clients who are pregnant receive screening testing for chlamydia at the first prenatal visit and rescreen in the third trimester. Complications if untreated: PID, premature rupture of membranes, postpartum endometriosis, Multiple sex partners and unprotected sex are the risk factors. Expected findings is dysuria, urinary frequency, vulvar itching, and gray and white discharge. Patient-centered care. Instruct the client to take the entire prescription as prescribed. Identify and treat all exposed sexual partners. Clients who are pregnant should be retested within 3 to 4 weeks after completing the prescribed regime. If continued sexual activity is desired, be aware of the sexually transmitted infection status of any sexual partners and use a barrier contraceptive each time you have sex. All states have reportable disease lists. Chlamydia is a commonly reported condition. It is the responsibility of the provider to report cases of these diseases to the local health department. Therapeutic management. Antibiotics, azithromycin by mouth, amoxicillin by mouth. Contraindicated during pregnancy is doxycycline and levofloxacin. Erythromycin is an ointment. It's administered to all newborns following birth. This is the medication of choice for ophthalmia neonatum. This antibiotic is bacteriostatic and bactericidal and thus provides prophylactic against Neisseria gonorrhea and chlamydia. Neisseria gonorrhea is the causative agent of gonorrhea. Gonorrhea is a bacterial infection that is primarily spread by genital to genital contact. However, it can be spread by anal to genital or oral to genital contact. It can also be transmitted to a newborn during birth. The CDC recommends all clients who are pregnant receive screening testing for gonorrhea at the first prenatal visit. Complications if untreated: salpingitis, PID, premature rupture of membranes, preterm birth, chorioamnionitis, and sepsis. Risk factors is multiple sex partners, unprotected sex practices. Expected findings is dysuria, pain in lower abdomen, yellowish-green vaginal discharge, and easily induced endocervical bleeding. Provide the client education regarding disease transmission, identify and treat all sexual partners, administer erythromycin to all newborns following birth, take all medications as prescribed. Clients who are pregnant should be retested for gonorrhea within 3 to 4 weeks to determine for medication effectiveness. Adhere to safe sex practices, and all states have reportable disease list. Syphilis. Syphilis is an STI caused by Spirochaete treponema pallidum. It can have long-term complications if not adequately treated. Syphilis has 3 stages. It can be transmitted through oral, vaginal, or anal sex, as well as transmitted to an unborn child. Though the rate of congenital syphilis has recently decreased, more cases of congenital syphilis are reported in the U.S. than cases of perinatal HIV infection. The CDC recommends that all clients who are pregnant receive screening testing for syphilis at the first prenatal visit and rescreened in the 3rd trimester. Healthy People 2030 reduce congenital syphilis and reduce the rate of syphilis. The assessment, multiple risk factors is multiple partners, unprotected sex. Expected findings related to the stage. Primary stage, the client can notice a chancre, which is painless papular lesion at the site of the infection. Chancres can progress to an ulcerated area. Clients who are female can report an inguinal lymph node edema, which can indicate internal lesions. Secondary stage, the client can notice skin rashes such as reddish-brown maculopapular rash on the palmar surface of the hands and soles of the feet. Latent phase, the client does not have any expected findings of syphilis present. Tertiary stage, damage to internal organs can occur for which clients can notice the manifestations, including difficulty coordinating muscle movements and blindness. Physical assessment findings. Primary stage, provider can observe a chancre in the genital area. Secondary stage, provider can observe skin rashes such as rough red or reddish-brown spots on the palms of the hands and soles of the feet. Blood tests, non-troponeal and troponeal. Non-troponeal tests are often used for screening, then troponeal tests for detecting antibodies specific for syphilis to confirm the diagnosis. This sequence of non-troponeal, then troponeal tests is considered the standard for testing. Microscopic examination of the primary lesion. Patient-centered care. Abstain from sexual contact until sores have completely healed. Partners need to be tested and treated. Adhere to safe sex practices. All states have reportable disease list. Medications. Benzathine penicillin. If the duration of the syphilis is unknown, 3 doses are recommended. If the client has an allergy to penicillin, desensitize and treatment with penicillin G. Contraindicated during pregnancy is doxycycline or tetracycline orally. Hepatitis B is a virus that is transmitted by contact via blood or sexual intercourse. It can also be transmitted to fetus during pregnancy. The CDC recommends all clients who are pregnant receive screening for hepatitis B surface antigen as part of their initial screening. Risk factors is multiple sex partners, unprotected sex practices, appointment in healthcare, injectable substance abuse, and recipient of multiple blood transfusions. Avoid medications that can affect the liver and cause problems. Encourage client to eat well-balanced diet and drink plenty of fluids. Explain condition to the client. Inform the client that household members and sexual partners will need immunoprophylaxis. Therapeutic management. Hepatitis B immunoglobulin vaccine is 14 days of recent contact. Group B streptococcus is GBS. This infection is a bacterial infection that can be passed to a fetus during labor and delivery. GBS is often as expected part of the vaginal flora for non-pregnant clients and present in some who are pregnant. Complications if untreated: preterm labor and birth, chorioamnionitis, infections of the urinary tract, maternal sepsis, endometritis after delivery, if transmitted to the neonate, pneumonia, respiratory distress syndrome, sepsis, and meningitis. Risk factors: prolonged rupture of membranes, preterm labor, low birth weight, use of intrauterine fetal monitoring. Laboratory diagnostic tests. Vaginal and rectal cultures are performed at 36 and 37 weeks gestation. Administer intrapartum antibiotic prophylaxis to following clients to decrease transmission neonate. Client who has GBS positive, has unknown GBS status, has maternal fever of 104, has a ruptured membranes for 18 hours or longer. Notify the labor and delivery nurse of GBS status and educate the client about conditions and its management. Medications. Penicillin G or ampicillin are most prescribed for GBS. Intrapartum is administered penicillin G initially, and then 4 hours initially do ampicillin, followed by the intermittent IV bolus every 4 hours. HPV or human papillomavirus is the most common STI. There are several strains of the virus. HPV strain 611 can cause genital warts. Other strains can affect the cervix and cause dysplasia or cancer. HPV can spread through oral, vaginal, and anal sex, most commonly vaginal or anal routes. During pregnancy, the lesions can expand and cause complications of pregnancy. The CDC recommends all clients who are pregnant receive a pap smear. Complications if untreated. Obstruction of birth canal. This interferes with fetal descent, which may necessitate cesarean delivery, which is called dystocia, and cervical cancer. Risk factors: multiple partners, unprotected sexual practices. Laboratory test is a pap test with or without HPV. Genital warts are diagnosed by the provider based on appearance during physical exam. Nursing actions is therapy may require multiple office visits. Consider abstinence or safe sex. If therapy is deferred until after birth, remember that the lesions are infectious. Prepare the client for cesarean birth. Lesion care: use oatmeal baths, keep lesions clean and dry, wear loose-fitting clothing. Medication for genital warts and condyloma is tricholacteric acid or TCA, or bichloractic acid, which is BCA. So TCA or BCA. Contraindicated after pregnancy is pondophilin, podophilox, Sanaxins, and imiquimod. Therapeutic procedures is cryotherapy. A client who has unexpected findings that require further evaluation on their pap smear, the provider may opt to treat and manage following birth. Trichomoniasis. Trichomoniasis is an STI caused by a protozoan parasite, Trichomonas vaginalis. It is considered the most prevalent non-viral STI. It can be spread penis to vagina or vagina to vagina. The CDC recommends that all clients with clinical findings receive testing. Complications if untreated: preterm birth, PROM, increased risk for contracting HIV, PID, and small gestational age or neonate. Expected findings is yellow-green frothy vaginal discharge with foul odor, dyspareunia and vaginal itching, dysuria. The physical examination is discharge in the vaginal vault during speculum examination, which can be sampled for microscope, strawberry spots on the cervix, which is tiny petechiae, and a cervix that bleeds easily. Laboratory and diagnostic tests is wet mount saline prep microscopically detects the presence of protozoa, cultures, urine specimens, and pap smear. The nursing actions is avoid alcohol while taking this medication for 3 days after treatment due to disulfiram-like reaction. Take all medications as prescribed. Refrain from sexual intercourse until partner has been treated. Encourage retesting within 3 months. And the medications is metronidazole by mouth. Bacterial vaginosis, or BV. BV is recommended for all clients who are pregnant and symptomatic. According to the CDC, routine screening for asymptomatic clients who are pregnant is not recommended. Complications if untreated is postpartum endometritis, increased risk for contracting other STIs, premature rupture of membranes or PROM, preterm birth, and infections related to amniotic fluid. Expected findings. Client may report vaginal pruritus, milky gray-white discharge, and a fishy odor. The diagnostic test is the whiff test, positive for fishy odor. Microscopic is the wet mount, normal, saline positive if clue cells are noted. And the medications is metronidazole by mouth, clindamycin by mouth, and it's contraindicated during pregnancy while breastfeeding. Avoid alcohol while taking metronidazole due to disulfiram-like reaction. Take all medications as prescribed. Treatment is not usually indicated for sexual partners. Candidiasis is also known as vulvovaginal candidiasis, or VVC, or yeast infection. It is a fungal infection most often caused by Candida albicans, but non-Candida albicans infections are possible. It is the second most common type of vaginal infection in the U.S. All clients who have manifestations should be tested, and during pregnancy, candidiasis is treated to relieve discomfort and prevent oral thrush in the neonate. Risk factors is pregnancy, diabetes, oral contraceptives, recent antibiotic treatment, obesity, and diet high in refined sugars. A lab test is sample of discharge used for application to pH paper, saline and potassium chloride wet mount smear, pH is less than 4.5, and the wet mount potassium hydroxide prep, which indicates presence of yeast buds, hyphae and pseudo-hyphae. Avoid tight-fitting clothing and wear cotton-lined underpants. Remove damp clothing as soon as possible. Avoid douching. Increase dietary intake of yogurt with active cultures. And if infections are recurrent or frequent, diabetes should be ruled out. COVID-19 is SARS virus that is caused by a new strain of coronavirus. The CDC and ACOG encourage all clients who are pregnant to get the COVID vaccine. This will prevent the occurrence of the condition since COVID-19 is a new condition. Currently, research is being conducted to provide more information about the condition and its management. Complications if untreated. Increased maternal and fetal mortality and morbidity. Maternal respiratory or cardiovascular conditions. Maternal may necessitate ventilator support or ICU admission, hypertension, heavy postpartum bleeding, and coagulopathies. Expected findings. Client may report cough, shortness of breath, fatigue, sore throat, and loss of taste and smell. Lab tests are rapid. Obtain nasal swab specimen or performed by or anywhere. Laboratory is nasal swab specimens, blood test, viral test, antigen, nucleic acid amplification, and PCRs. Torch infections. Torch are multiple conditions that can affect a client who is pregnant and the fetus in utero. These infections include toxoplasmosis, other infections like hepatitis, rubella, cytomegalovirus, and herpes. These infections can cross the placenta and have teratogenic effects on the fetus. Torch does not include all the major infections that present risks to the mother and fetus. Screening's torch infections would be as indicated depending on the client's symptoms. There is a torch screen, immunologic survey used to identify existence for these infections in the mother, to identify fetal risks, or newborn. This is the detection of antibodies against the infections. The risk factors are toxoplasmosis is caused by a protozoa. Toxoplasmosis is caused by consumption of raw or undercooked meat or handling cat feces. Other infections can include hepatitis A and B, syphilis, mumps. These are some of the most common and can be associated with congenital anomalies. Rubella is contracted through children who have rashes or neonates who are born to clients who have rubella. Cytomegalovirus is transmitted by droplet infection from person to person through semen, cervical and vaginal secretions, breast milk, placental tissues, urine, feces, and blood. A latent virus can be reactivated and cause disease to the fetus in utero during passage through the birth canal. HSV is spread by direct contact with oral or genital lesions. Transmission to the fetus is greatest during vaginal birth if the client has active lesions. Toxoplasmosis is often asymptomatic. Manifestations are similar to influenza or lymphadenopathy, which is malaise, muscle aches, and flu-like manifestations. Rubella is joint and muscle pain, rash, and fever. Cytomegalovirus is manifestations or mononucleosis-like manifestations. HSV, client may report multiple painful blisters on genital area, itching, fever, malaise, and tender lymph nodes. Lesions that appear as vesicles, then pustules, and ulcerate and form crusts. Client education. Discuss safe sexual relations with client. Provide client with emotional support. Toxoplasmosis. Client may experience immunity after first incident. Adhere to prevention practices, including correct hand hygiene and cooking meat properly. Avoid contact with contaminated cat litter. Rubella. For rubella, immunization of clients who are pregnant is contraindicated because rubella infection can develop. These clients should avoid crowds and young children. Clients who have low titers prior to pregnancy should receive immunization. Cytomegalovirus is reinforced with client about condition. Encourage client to use proper hand washing to prevent exposure by frequent hand hygiene before eating and after handling newborn diapers and toys. HSV. A cesarean birth is recommended for all clients in labor who have active genital herpes lesions or early findings of impending outbreak. Refrain from sexual intercourse during third trimester with partners known or suspected of having HSV. Routine screening for HSV is not recommended. Prior to birth, ask client about history of HSV. Medications. Toxoplasmosis. Treatment for toxoplasmosis includes sulfonamides or a combination of pyrimethamine and sulfazine. Potentially harmful to the fetus, but parasitic treatment is essential. Rubella vaccination is received postpartum because of fetus in utero. Clients should avoid pregnancy for at least 1 month after receiving the vaccine. HSV is acyclovir by mouth, IV if severe, and valacyclovir is by mouth.